Welcome back to another episode of Second Career Pilot.
Great to be here.
Today, we're tackling something absolutely vital for every pilot, especially those of you who are just beginning your aviation journey, aeromedical factors.
hmm
Think of this as, well, your foundational understanding of how your body and mind interact with the unique environment of flight.
Exactly. It's pretty crucial stuff.
We'll be exploring medical certifications, the potential health challenges you might encounter in the air, and, crucial strategies for staying safe and sharp every single time you take to the skies.
Yeah.
Our aim isn't to overwhelm you, but really to equip you with essential knowledge that will make you a more informed and ultimately a safer pilot.
That's right. Whether you're dreaming of those first solo flights or planning longer cross countries, understanding the basics of aeromedical factors is just non-negotiable.
Non-negotiable. I like that.
It's about recognizing your limitations and knowing how to mitigate risks.
Okay, let's unpack this, starting with medical certification. Now, for most pilot activities, a valid medical certificate is, well, it's a must-have. Can you walk us through why that is and maybe what the exceptions might be?
Certainly. So for the majority of pilot certificates, we're talking private, recreational, commercial, and airline transport. Holding a valid medical certificate is a regulatory requirement. Simple as that.
Okay.
This is in place basically to ensure that pilots meet certain minimum health standards for the safety of flight. Makes sense? Right.
Absolutely. But you mentioned exceptions.
Right. There are a few key exceptions. Glider pilots and free balloon pilots. They're not required to hold a medical certificate.
Interesting.
Additionally, sport pilots have an option. They can fly with either a medical certificate or just a valid state driver's license, under specific limitations, of course.
That's good to know about the exceptions.
Mhm.
But even if you don't need a formal medical in those specific cases, there's still a crucial rule every pilot needs to be aware of, right?
Absolutely, spot on. Regardless of whether a medical certificate or just a driver's license is required, 14 CFR 61.53 is crystal clear.
61.53.
Got it. It says every pilot is prohibited from acting as a crew member if they know, or importantly have reason to know, of any medical condition that would make them unable to operate the aircraft safely.
So it's a personal responsibility thing.
It's a fundamental responsibility for all of us in the cockpit. Absolutely.
Makes perfect sense. So for those needing a medical certificate, what's the process for getting one? How does that work?
Okay, the journey to obtaining a medical certificate, it begins with an examination by an aviation medical examiner, or AME.
Amy. Okay.
These are physicians with specialized training in aviation medicine.
Mhm.
They're designated by the FAA's Civil Aerospace Medical Institute, or
Okay.
BMI.
And we hear about different classes of medical certificates. What's the difference between them and which one do you need for what type of flying?
Good question. There are 3 classes:
Yes.
third class, second class, and first class.
1, 2, 3.
Pretty much. The class you need depends on the type of pilot certificate you hold and the privileges you're exercising. So for a private or recreational pilot certificate, a third class medical is what you need.
Okay, third class for private rec. How long is that good for?
It's valid for 5 years if you're under 40 and for 2 years if you're 40 or older.
5 or 2, depending on age.
Got it.
What about commercial?
For a commercial pilot certificate, you need at least a second class medical. That one's valid for 1 year, regardless of age.
1 year for second class, and then first class must be for airline pilots.
Exactly. First class medical certificates are required for airline transport pilots, ATPs, and their validity is a bit shorter, again, 1 year if the pilot is under 40 and only 6 months if they are 40 or older.
Okay, so it sounds like the requirements definitely get more stringent as the level of flying increases. Makes sense.
It does.
And what if you hold, say, a first class medical, but you're just flying for fun on the weekend, exercising private pilot privileges?
That's a good point. If you hold a higher class medical, like a first class, you automatically meet the requirements for the lower classes.
Okay.
But the validity period changes depending on the privileges you're actually using at that time.
Ah, right.
So, for example, that first class medical might be valid for only 6 months for ATP privileges if you're over 40, but it would be valid for a full year if you're using it to exercise commercial privileges, and for 2 or even 5 years for private or recreational flying, depending on your age.
So the certificate itself doesn't change, just how long it's valid for, depending on what you're doing.
Precisely. The same principle applies to a second-class medical being used for private flying.
What about student pilots? Say someone has maybe some physical limitations. Is there a pathway for them to get started in aviation?
Yes, absolutely. Students with physical limitations, maybe impaired vision, loss of a limb, or hearing impairment, They can be issued a medical certificate that's specifically valid for student pilot privileges only while they're learning.
Okay, that's encouraging.
Often, these pilots might need special equipment in the aircraft. And in some cases, there might be limitations placed right on their certificate, like not valid for flight requiring the use of radio if they have a significant hearing impairment, for example.
And I've heard about something called a Statement of Demonstrated Ability, or SOTA. What's that all about?
The SOTA. It's a special authorization, basically. It can be issued when a student pilot, or really any pilot with a disability, can demonstrate their ability to operate the aircraft safely despite their physical impairment.
So they prove they can fly safely with the limitation.
Exactly. It shows they can meet the normal level of safety. And these SOTAs remain valid as long as the impairment doesn't get worse.
Who would you talk to about getting one of those?
If you have questions about this, the best point of contact is your local Flight Standards District Office, the FSDO.
FSDO.
Yeah.
Got it. Now, I know there's a list of specific medical conditions that can be disqualifying.
Huh.
It sounds a bit daunting, honestly. Can you shed some light on that?
Yes, you're right. 14 CFR Part 67 lists 15 specific medical conditions that are considered disqualifying based on your medical history or clinical diagnosis.
15 specific ones. Okay.
Yeah, it's quite a list. It includes conditions like diabetes requiring medication, angina pectoris, coronary heart disease.
Heart stuff.
Yeah, a history of heart attack, cardiac valve replacement, having a permanent pacemaker, or even a heart transplant. Also, certain psychiatric conditions like psychosis and bipolar disorder, severe personality disorders,
Okay.
substance dependence or abuse, epilepsy, any unexplained disturbances of consciousness, and unexplained transient loss of control of nervous system function.
Wow, that's a pretty significant list.
Hmm.
Does that mean if you have any of those conditions, your flying career is just over?
Not necessarily, and this is really important for people to understand.
Okay.
What's fascinating here is that with very few exceptions, most of these disqualifying medical conditions can actually be considered for what's called a special issuance authorization.
Special issuance, so like a waiver.
Kind of. If you can provide satisfactory medical documentation to the FAA showing that your condition is stable and well managed, there's often a good chance you might still be able to qualify for a medical certificate.
So there's hope, even with those conditions.
Absolutely. The FAA Federal Air Surgeon makes these discretionary decisions after reviewing special testing and all the medical evidence.
That's really encouraging to hear.
Right.
So it's not always a definitive no.
Yeah?
What about other medical conditions that aren't on that specific list of 15?
Right. Even if a condition isn't on that list, there are many other medical conditions that the FAA reviews. These fall under the General Medical Conditions section of the regulations.
Okay.
And they can still be considered disqualifying. Examples might include things like cancer, kidney stones, various neurological and neuromuscular conditions, certain blood disorders, things like that.
So still potentially an issue.
They often require FAA review before a medical certificate can be issued, especially if they are conditions that might progress or change over time.
So the key takeaway seems to be, if you have any medical condition, really, the best course of action is always to be upfront, work closely with an AME, and work with the FAA to explore all the possible avenues.
Absolutely. Transparency and providing thorough medical documentation are just crucial. You said it.
Okay.
Now, maybe we should shift gears a bit. Let's talk about some of the health and physiological factors that can directly affect your performance once you're actually in the air.
Right. This is where it gets really practical in the cockpit.
Exactly. This is where understanding how your body reacts to the flight environment becomes so important.
Okay, things like hypoxia, ear and sinus issues, spatial disorientation. It can sound a bit scary, but understanding it is definitely key to staying safe.
Yeah.
Let's start with hypoxia. What exactly is it, and why is it such a big concern for pilots?
Hypoxia, in simple terms, just means reduced oxygen. For pilots, the primary concern is the lack of sufficient oxygen reaching the brain. Why? Because the brain is incredibly sensitive to oxygen deprivation. Even a slight reduction in mental function while flying can lead to critical errors.
Yeah, you don't want that.
Definitely not.
And I understand there are different types of hypoxia, like different causes.
That's right. There are 4 main forms, and sometimes remembering them by their cause helps. Think high altitude, lack of available oxygen.
Okay, high altitude, that's hypoxia.
Correct. Hypoxia, insufficient oxygen available to the body as a whole, like at high altitudes where the partial pressure of oxygen is just lower. Or even, interestingly, carrying dry idle improperly can cause it by displacing oxygen with CO2.
Wow, dry ice. Didn't think of that.
Yeah, need proper ventilation. Then there's hypomic hypoxia.
Hypomic, like anemia.
Exactly. The blood isn't able to carry enough oxygen. Carbon monoxide poisoning is a classic example here because CO binds so strongly to hemoglobin. Blood donation can even cause a temporary risk.
Okay, so hypoxic altitude, hypomic blood. Sit down.
Stagnant hypoxia. This is when oxygen-rich blood isn't flowing properly to the tissues. Think shock, heart failure, or even just pulling excessive G-forces or being really cold affecting circulation.
Stagnant, like stuck blood flow. Got it. And the last one.
Histotoxic hypoxia. Here, the cells themselves can't effectively use the oxygen that is available.
What causes that?
Alcohol and certain other drugs or poisons are the main culprits. Interestingly, just 1 ounce of alcohol can have a physiological effect equivalent to being 2,000 feet higher in altitude.
Wow, that's sobering. Literally. So what are some of the symptoms a pilot might experience if they're becoming hypoxic? How would you know?
Well, the symptoms can vary a lot from person to person, which is part of the danger.
Okay.
But some common ones include cyanosis, that's a bluish tint to the fingernails and lips.
No, it's not lack of oxygen.
Yep. Also headache, slowed response time, definitely impaired judgment, sometimes even a weird feeling of euphoria.
Euphoria. That seems counterintuitive.
It does, but it happens. Also visual impairment, drowsiness, feeling lightheaded or dizzy. And a particularly dangerous aspect is that hypoxia can give you a false sense of security, making it hard to recognize you're not thinking clearly.
That is dangerous. So what's the immediate treatment if you suspect hypoxia? What do you do?
Immediately, descend to a lower altitude and use supplemental oxygen if it's available.
Get low, get O's.
Exactly. It's crucial to act quickly because the time of useful consciousness, that's the window you have to make rational decisions without enough oxygen, it decreases really rapidly as your altitude increases, especially above 10,000 feet.
You mentioned earlier experiencing hypoxia in an altitude chamber. That sounds intense. Is that something pilots should consider doing?
Absolutely, if they have the opportunity. Experiencing the effects of hypoxia in a controlled environment like an altitude chamber, the FAA offers this at AVNI, and many military facilities have them too. It can be incredibly valuable.
How so?
It helps pilots recognize their own personal symptoms, which can be subtle, and really drives home the critical need for oxygen discipline at altitude.
Okay, that makes a lot of sense. Let's move on to hyperventilation. It sounds almost like the opposite of hypoxia, but can it also be a problem for pilots?
Yes, definitely. Hyperventilation is kind of the opposite in terms of carbon dioxide levels, but interestingly, it can present with some surprisingly similar symptoms to hypoxia.
Similar symptoms. Like what?
Well, hyperventilation is when you breathe too rapidly or too deeply, leading to an excessive loss of carbon dioxide from your blood.
Usually from stress, right?
Yeah, it often happens in stressful situations, or sometimes even at higher altitudes, even if you are using oxygen correctly. Symptoms can include visual impairment, lightheadedness or dizziness, tingling sensations, hot or cold flashes, muscle spasms. In severe cases, it can even lead to unconsciousness.
So if the symptoms overlap with hypoxia, how do you know which it is?
That's the tricky part. It's vital to try and make the correct diagnosis. If you're using oxygen, the first step is always double-check your equipment to ensure you're actually getting oxygen and it's flowing correctly.
Good point. Check the gear first. And if it is hyperventilation, how do you treat it?
The key is to restore a normal breathing pattern and get those carbon dioxide levels back up to normal. Consciously slowing your breathing rate is the best approach.
Slow down the breathing.
Yeah. Some old techniques like breathing into a paper bag work on that principle, or even just talking aloud can sometimes help regulate your breathing. Recovery from hyperventilation is usually quite rapid once you get your breathing under control.
Okay. We've covered oxygen issues, too little and too much CO2 loss. What about the physical pressures of flight, like changes in altitude affecting our ears and sinuses? That seems really common.
Oh, very common issues for pilots, especially student pilots. During climbs and descents, the air pressure in our body cavities, like the middle ear and sinuses, needs to equalize with the changing pressure in the cabin. If it doesn't, you feel it.
Let's start with the middle ear. How does that pressure equalization work, and what can go wrong? I think everyone's felt that ear pop.
Right. The middle ear is connected to the back of your throat by the eustachian tube. Normally, this tube opens briefly when we chew, yawn, or swallow, allowing the pressure on either side of the eardrum to equalize. That's the pop. During a climb, the pressure inside the middle ear becomes higher than the cabin pressure, causing the eardrum to bulge outward. You might feel that as fullness before it pops or clears.
And descent is usually worse.
Often, yes. During descent, the cabin pressure increases. becoming higher than the pressure in the middle ear. This makes the eardrum bulge inward. It can be harder to relieve because the lower pressure inside the ear can sort of suck the eustachian tube closed.
Right, the vacuum effect.
Yeah.
So what can pilots do to help equalize that pressure during descent? Pinching your nose, right?
Yep. The Valsalva maneuver is the standard.
Yeah.
You pinch your nostrils shut, close your mouth, and then gently try to blow out through your nose. This forces air up the eustachian tubes.
Gently being the key word.
Very gently, yes. It's also really important to avoid flying if you have a significant cold, ear infection, or a bad sore throat. That congestion can make equalization very difficult, painful, and potentially damaging.
What about minor congestion?
Nasal sprays or drops might help for minor stuff, but it's always best practice to check with your AME before using any medication before flying.
Good advice. And the sinuses work in a similar way, right? Pressure needs to equalize there, too.
Exactly. The sinuses are also air-filled cavities, and they connect to your nasal passages through small openings. Just like the middle ear, the pressure inside needs to match the outside.
And congestion blocks those openings.
Right. If you have congestion from a cold or allergies, these openings can become blocked or narrowed, slowing down or preventing equalization. This sinus block is most common during descent as the pressure difference increases.
Ouch. What are the symptoms of a sinus block? How would you know?
It can cause significant pain, usually felt over the affected sinus, maybe in the forehead area above your eyebrows, or in the upper cheek area. Sometimes it can even feel like a toothache if it's the maxillary sinuses. You might also notice some bloody mucus afterward.
Doesn't sound fun. How can pilots prevent or deal with it?
Best prevention is simply not flying when you have an upper respiratory infection or significant nasal allergies. If it happens, unfortunately, decongestant sprays often don't reach those sinus openings well, and oral decongestants can have side effects that might impair your flying ability.
So write it out and see a doctor if it persists.
Pretty much.
Yeah.
If a sinus block doesn't clear shortly after landing, it's definitely a good idea to consult a physician.
Okay, we've covered a lot about the physical body's response. Let's move on to how our perception can be affected in flight, specifically spatial disorientation and illusions. This sounds like a really critical area, especially for new pilots operating in limited visibility.
It is indeed hugely critical. Spatial disorientation is essentially a lack of accurate orientation regarding your aircraft's position, attitude, or movement in space. It's when you don't know which way is up, basically.
And it happens because our senses get confused.
Precisely. Our bodies rely on 3 integrated systems to maintain balance and orientation. The vestibular system in the inner ear, which senses motion.
The inner ear balance stuff.
Yep. Then the somatosensory system, which involves our sense of touch, pressure, and body position. Think seat of the pants flying.
Right.
And finally, our visual system, our eyes.
And what happens when these systems give us conflicting information, like in clouds or fog?
That's exactly when disorientation occurs. Most of the time on the ground, or in clear visual conditions, VMC, these systems agree, and our visual system usually dominates and keeps us oriented correctly with the horizon.
But take away the visual cues.
Take away those visual cues, like when flying in instrument meteorological conditions, IMC, at night over dark areas or in fog, and the other senses can provide powerful, compelling, but misleading information. This leads to illusions.
So without seeing the horizon, our sense of balance can really play tricks on us. What are some of the common vestibular illusions, the inner ear ones, that pilots might experience?
There are several well-known ones. The leans is probably the most common.
The leans.
Yeah. Imagine you've been in a slow, gradual turn, maybe less than 2 degrees per second, which is below the threshold your inner ear can detect. You don't even feel it.
Okay.
Then you suddenly notice it on the instruments and roll back to level flight. Your inner ear fluid, which had caught up to the turn, now feels a roll in the opposite direction. So you feel like you're banking the other way, and your instinct is to lean back into the original incorrect turn.
Wow. Okay. That sounds easy to fall into.
Hmm.
What else?
The Coriolis illusion is another nasty one. This can happen if you make a sudden head movement while you're in a prolonged turn. Moving your head in a different plane disrupts the inner ear fluid, creating a strong, false sensation of turning or accelerating on a completely different axis. Very disorienting.
So keep your head still during instrument flight.
Minimize head movements, especially abrupt ones during instrument cross-check or if you drop something. Then there's the graveyard spiral.
That sounds ominous.
It is. In a prolonged, coordinated turn, you might lose the sensation of turning altogether. If the aircraft then starts losing altitude, which it naturally does in a turn unless you add power or back pressure, and you try to correct the descent by pulling back on the yoke without leveling the wings because you don't feel the turn.
You just tighten the turn and descend faster.
Exactly. You tighten the spiral and increase the descent rate, potentially fatally.
Geez. Are there others related to acceleration?
Yes, the symmetrographic illusion. Rapid acceleration, like during takeoff, pushes you back in your seat. Your body interprets this as tilting backwards, creating a false sensation of a nose-up attitude.
So you might push the nose down.
Precisely. Dangerous right after takeoff. Rapid deceleration has the opposite effect, feels like pitching down, so you might pull the nose up towards a stall.
Okay, so metagravic is acceleration, deceleration. What else?
There's the inversion illusion. An abrupt change from a climb to level flight can make you feel like you're tumbling backward, leading you to push the nose low. And the elevator illusion, an abrupt updraft, can feel like a climb, causing you to push the nose down, or a downdraft feels like a descent, making you pull the nose up.
It's really clear that relying on our physical senses alone in flight, especially without visual cues, is incredibly risky. What about visual illusions? Those must be just as important to understand, even when you can see outside.
Absolutely. Since pilots rely so heavily on vision, visual illusions can be particularly hazardous, especially during approach and landing.
Like mistaking lights for the horizon.
Yeah. Exactly. One common one is the false horizon. Sloping cloud formations, an obscured horizon, ground lights scattered on hilly terrain, even things like the aurora borealis can be mistaken for the actual horizon. This can lead you to fly with a dangerous bank angle without realizing it.
Okay. What else visually?
Autokinesis. This happens usually at night. If you stare at a single stationary point of light against a dark background for several seconds, it can appear to move.
The light isn't actually moving.
Nope. But if you try to follow the perceived movement, you could lose control of the aircraft. The key is to keep scanning, don't fixate.
Good tip. And these illusions are even more pronounced during landing, I imagine. That seems like a critical phase.
Yes, optical illusions during the landing phase are a significant factor in many accidents. These arise from various terrain features and atmospheric conditions, and they primarily mess with your perception of altitude and distance from the runway.
Can you give us some examples of these landing illusions, how the runway itself can trick you?
Certainly. A classic is the runway with delusion. A narrower than usual runway can create the illusion that you're higher than you actually are.
So you fly lower approach.
Exactly, which risks hitting obstacles or landing short. Conversely, a wider than usual runway can make you feel lower than you are, causing you to fly a higher approach, potentially leading to leveling off too high, a hard landing, or even overshooting the runway.
Okay, runway width. What about slopes?
Runway and terrain slopes illusion. An upsloping runway or surrounding terrain can make you feel higher, again leading to a lower approach. A downsloping runway or terrain makes you feel lower, leading to a higher approach.
It seems like a lot of these make you think you're higher than you are.
Many do, yes. Like the featureless terrain illusion. Flying an approach over water, dark, or snow-covered areas at night gives very few visual cues for altitude judgment. This makes you feel higher, leading to a dangerously low approach, sometimes called the black hole approach.
Black hole approach, okay. Any others? Weather-related?
Sure. Water refraction rain on the windscreen can make the horizon appear lower, creating the illusion you're higher, so you fly lower. Haze makes things look farther away and higher than they are, so you tend to fly low. Clear air can do the opposite. Fog can create an illusion of pitching up, causing pilots to steepen their approach abruptly.
And ground lights at night.
Ground lighting illusions. Strings of lights along a road could be mistaken for runway lights. Also, bright runway lights in very dark surroundings can make the runway seem closer than it is, causing you to fly a higher approach.
Those are all crucial things to be aware of, especially when approaching an unfamiliar airport or in bad weather. What are some key ways pilots can prevent landing errors due to these optical illusions? How do you fight back?
Prevention is key. First, anticipate these possibilities, especially at unfamiliar airports or in challenging conditions. Always check airport diagrams and the chart supplement beforehand for runway dimensions, slope info, terrain, and lighting systems.
Do your homework.
Absolutely. Second, make frequent checks of your altimeter during the approach. Don't just rely on the visual picture.
Trust the instruments.
Third, if possible and safe, conduct an aerial visual inspection of the airport area before committing to land. Fourth, Use visual approach aids like VSI or PAPI systems or electronic glide slopes whenever they're available. They're designed to combat these illusions.
Use the tools you have.
Exactly. Also, be aware that distractions or emergencies significantly increase your susceptibility. Maintain focus and, most importantly, maintain proficiency in standard landing procedures. Practice.
It sounds like being proactive,
Mm.
using all available information, technology, and staying proficient is really the key to combating these sensory and visual illusions.
That sums it up well.
Now, let's quickly talk about something that can affect pilots, especially early in their training. Motion sickness. Seems less dangerous, but still unpleasant.
Right. Motion sickness, or air sickness, happens when your brain gets conflicting messages about your body's state from your inner ear, your eyes, and your other senses. It's quite common during initial flights as your body adapts.
And stress makes it worse.
Anxiety and stress can definitely contribute. Symptoms usually include discomfort, nausea, maybe dizziness, paleness, sweating, and sometimes vomiting.
What should a student do if they feel it coming on?
Tell your instructor immediately. It's nothing to be embarrassed about. It doesn't reflect on your ability. Often simple things help. Opening fresh air vents, focusing on a point far outside the airplane, like the horizon, and trying to avoid unnecessary or sudden head movements.
Can you take medication for it?
Medications like Dramamine can help passengers, but they usually cause drowsiness, so they're generally not recommended for pilots while flying. It typically gets better with experience.
Okay. Another invisible threat we should cover is carbon monoxide poisoning. You mentioned it briefly with hypoxia. It's odorless, colorless, very dangerous.
Extremely dangerous for exactly that reason. Carbon monoxide, CO, is a byproduct of the combustion in your engine. It gets into your blood and binds to hemoglobin way, way more effectively than oxygen does, like 200 times more readily.
So it essentially kicks the oxygen out.
Pretty much. It prevents your blood from carrying oxygen to your cells and tissues, leading to hypoxia. And the scary part is it can take your body a long time, up to 48 hours, to fully eliminate CO once it's built up. High concentrations can be fatal quickly.
How does it typically get into the aircraft cabin? Through the heater.
That's the most common route, yes. Via the heater or defrost vents, especially if there's a leak or damage in the engine exhaust system, allowing exhaust gases to mix with the cabin air.
Are there warning signs? You said it's odorless.
While CO itself is odorless, sometimes you might smell exhaust fumes if there's a significant leak, and that's a huge red flag. But you can have dangerous levels of CO without any smell at all.
So how do you protect yourself?
Having a disposable CO detector in the cockpit is highly recommended. They're inexpensive and change color in the presence of CO, giving you a visual warning.
What are the symptoms if you're getting exposed?
Symptoms can mimic the flu or fatigue initially. Headache, maybe blurred vision, dizziness, drowsiness, muscle weakness.
What's the immediate action if you suspect CO? Smell exhaust, detector changes color, feel symptoms.
Immediate action. Turn off the cabin heater immediately. Open fresh air vents and windows fully. Use supplemental oxygen if you have it. And consider landing as soon as practical. Don't ignore the signs.
Got it. Heater off, vents open, oxygen on. Crucial. Let's shift briefly to some of the more chronic factors.
Wow.
Stress and fatigue. How do these affect a pilot's ability to fly safely?
They have a huge impact. Stress is just the body's response to demands. It can be acute, short-term fight or flight, which can actually sometimes enhance performance briefly, but it burns you out.
Right.
Chronic stress, though, the long-term stuff from work, life, whatever that's really detrimental, it creates an intolerable burden and significantly reduces your ability to cope and perform. Pilots experiencing significant chronic stress really shouldn't be flying and should seek help.
And fatigue. Seems like it goes hand in hand with stress sometimes.
Often does. Fatigue is a major, major factor in pilot error. It degrades everything: attention, concentration, coordination, communication, decision-making. Just makes you sloppy and prone to mistakes.
Is it just lack of sleep?
It can be physical fatigue from sleep loss or exertion, yes, but also mental fatigue from stress, prolonged concentration, or difficult cognitive work. And like stress, there's acute fatigue, normal tiredness cured by rest, and chronic fatigue.
Chronic fatigue sounds serious.
It is. It often has deeper psychological roots, isn't relieved by just sleep, and usually requires seeing a physician. It can present with symptoms like persistent weakness, palpitations, irritability, aches and pains. Pilots suspecting chronic fatigue need medical advice.
What about just normal acute fatigue, feeling tired after a long day?
Even acute fatigue is dangerous in the cockpit. If you're acutely fatigued, you should not fly. Period. The only cure is adequate rest and sleep. Avoid flying after pulling an all-nighter, after an unusually stressful day, or when you just feel worn out. Prioritize rest.
Good advice. Okay, quickly. Pilots handle chemicals like fuel, oil, hydraulic fluid during pre-flight. Any quick safety tips there?
Yeah, basic awareness is good. Always know what you're handling. The Material Safety Data Sheet, MSDS, has detailed info but general rules. Avoid eye contact, flush thoroughly with water if it happens. Minimize skin contact, wash off promptly, remove contaminated clothes. Avoid inhaling vapors, ensure good ventilation. Never ingest, seek immediate medical help if that happens. Basic chemical safety.
Makes sense. What about dehydration and heat stroke, especially flying in the summer?
Very important, especially in general aviation cockpits, which can get hot. Dehydration is just a critical loss of water. Hot cockpits, wind, low humidity, even diuretic drinks like coffee contribute.
And the first sign is fatigue.
Yes, fatigue is usually the first effect, which directly impacts performance. Your thirst mechanism actually lags behind your body's need for water, so you can be dehydrated before you even feel thirsty.
So drink water proactively.
Absolutely. Carry water, drink it regularly, especially on longer flights or hot days. Aim for maybe 2 to 4 quarts throughout the day as a rough guide. Limit coffee and caffeine. Heat stroke is the more severe progression where your body just can't regulate its temperature anymore. Prevention is key. Hydrate, ventilate the cockpit, wear light clothing.
Okay, two big ones left. Alcohol and drugs. These seem obvious, but the specifics are important.
Extremely important. Alcohol, even in very small amounts, impairs judgment, responsibility, coordination, vision, memory, reasoning, basically everything you need to fly safely.
Even just one drink.
Studies show even 1 ounce can slow reflexes and impair eye movements. Plus, the effects are significantly amplified by altitude. Alcohol interferes with the brain's ability to use oxygen. It causes histotoxic hypoxia.
Right, you mentioned that. What are the actual rules?
The regulations, 14 CFR Part 91, are clear. At least 8 hours must pass between drinking any alcohol and acting as a crew member. And your blood alcohol concentration must be less than 0.04%.
8 hours, A&D less than 0.04.
Correct. Both must be true. And even if it's been more than 8 hours, if your BAC is still 0.04% or higher, you can't fly. Also, remember, hangovers mean you're still under the influence physiologically. The safest bet is to be much more conservative than the regs, maybe 12 hours or even 24 hours after drinking.
Okay, be conservative with alcohol. What about drugs? Prescription, over-the-counter.
Similar rules apply. 14 CFR 61.53 prohibits flying if you have a medical condition or are taking medication that makes you unable to meet your medical certificate requirements. And 91.17 prohibits using any drug that affects your faculties in a way contrary to safety.
So basically any drug that could impair you is a no-go.
Pretty much. Thousands of medications, even common OTC ones like antihistamines or decongestants, can cause drowsiness, impaired judgment, or other side effects. Benadryl, for example, is known for causing significant drowsiness.
What about painkillers or sedatives?
Strong painkillers, tranquilizers, sedatives definitely impairing. Even some antibiotics can have side effects. And crucially, the underlying condition you're taking the medication for might itself be disqualifying.
So it's the drug A&D, the condition.
Yes. The FAA considers both. Illicit drugs are obviously completely forbidden. Marijuana use is prohibited for pilots under federal law, regardless of state laws.
What's the safest rule then?
The safest rule is do not fly as a crew member while taking any medication unless it's been specifically approved by the FAA or your AME. When in doubt, ask your AME.
And that leads into the IMSAFE checklist, right?
Exactly. A vital self-assessment before every single flight. Illness, medication, stress, alcohol, fatigue, emotion. For medication, ask yourself, am I taking anything that might affect my judgment or cause drowsiness? A good personal rule is to wait at least 48 hours after taking the first dose of any new medication, prescription, or OTC to see if you have any side effects before flying.
Good rule of thumb, 48 hours.
And generally, don't take unnecessary meds, eat well, stay hydrated, get enough sleep, stay fit. It all contributes.
Okay, nearly there. Altitude-induced decompression sickness, DCS. Sounds like something scuba divers worry about.
Pilots can get it too, though it's less common than in diving. It's caused by nitrogen bubbles forming in your body tissues due to the rapid decrease in ambient pressure at higher altitudes.
Like the bends.
Exactly. Joint pain, the bends, is the most common symptom. If you suspect DCS at altitude, 100% oxygen immediately, emergency descent, land as soon as possible, and seek medical evaluation from someone familiar with aviation or diving medicine. Hyperbaric chamber treatment might be needed.
And what about flying after scuba diving? That's a common question.
Very common. Diving increases the nitrogen load in your body. Flying too soon after can trigger DCS even at cabin altitudes that are normally safe.
So there are waiting times.
Yes, the FAA recommends specific waiting times before flying to certain altitudes. Generally, wait at least 12 hours after a non-decompression stop dive before flying up to 8,000 feet MSL. Wait 24 hours after a dive that required decompression stops, or for any dive if you're flying above 8,000 feet MSL.
Better safe than sorry there.
Definitely. These times account for the risk of an unexpected aircraft decompression, too.
Okay, last major topic. Vision in flight. Hugely important.
Arguably the most important sense for flying safely. But our vision has limitations, illusions, blind spots. Understanding how our eyes work helps mitigate risks.
How does night vision differ? That seems particularly challenging.
It is. At night, we primarily use the rods in our retinas, which are great for detecting motion in dim light, but poor for detail and color. Cones, used for color and detail in daylight, are concentrated in the center of our vision, the fovea, and don't work well in low light.
So you have a blind spot at night.
Effectively, yes. There's the physiological blind spot where the optic nerve connects, which we usually don't notice. But at night, the fovea itself becomes a night blind spot because it lacks rods. To see something clearly at night, you need to use off-center viewing, look about 5 to 10 degrees to the side of the object.
Look aside it to see it.
Okay.
And dark adaptation takes time.
It does. Your rods take about 30 minutes to become fully dark adapted. Bright light exposure resets this, so protecting your night vision before and during flight is key.
How do you protect it?
Wear sunglasses during the day before night flight. Keep cockpit lighting as low as possible. Dim white is usually best for reading charts. Avoid flying directly over brightly lit areas. And crucially, ensure adequate oxygen. Hypoxia dramatically degrades night vision, even at relatively low altitudes like 4,000 or 5,000 feet.
Oxygen helps night vision. Good to know. Any specific night vision illusions?
Yes. Besides autokinesis and false horizons, which we mentioned, things like difficulty judging distance and depth perception are amplified. Ground lights can be mistaken for stars or other aircraft. Flicker vertigo from strobe lights flashing through the propeller can be nauseating or worse. Landing illusions are also more pronounced at night.
So night flying requires extra caution and preparation.
Absolutely. Thorough pre-flight planning, knowing the route and terrain, having alternates, using supplemental oxygen, even when not strictly required by regs, these are all smart practices. And new technologies like synthetic vision, SVS, and enhanced flight vision systems, EFVS, are really improving situational awareness at night, too.
Wow. That wraps up our exploration into the world of aeromedical factors for new pilots. It's a lot to take in, but clearly essential.
It really is. Remember, understanding these aspects isn't just about passing a medical exam. It's about being a safe, responsible, and well-informed aviator every time you fly.
We've covered a ton today, from the nuts and bolts of medical certification to the subtle but critical ways your body and senses can be affected by flight.
And this is just the beginning of your learning journey. Keep revisiting these concepts, ask questions, especially of your instructor and AME, and deepen your understanding as you gain experience.
Definitely. It's all about building that knowledge base for safer flying.
Couldn't agree more.
Thanks for listening.